Thank you, everyone. It's 55 minutes after the hour, and we'll go ahead and get started. We'll launch today, or this morning session with the MMR Vaccine Work Group. Ms. Lynn Bata is chair of the MMR Vaccine Work Group, and I'll hand it over to her to provide the introduction and overview.
Thank you, and good afternoon. I was calculating it was going to be afternoon. I'm here to introduce the MMR work group and the work it is pursuing related to MMR vaccine. Next slide. High MMR vaccination coverage has been the major contributor in the elimination of measles in 2000 and rubella in 2004 in the U.S. and a more than 99% reduction in mumps cases. And as we know that measles and rubella remain endemic in many parts of the world, and that mumps is still endemic worldwide, and that these viruses continue to cause both locally acquired and importation-related cases and outbreaks. And this is the recent data over the past 5 years between 2016 and 2021. We've seen a low of 13 cases per year and a high of nearly 1,300 cases for measles and mumps. We've seen between 154 and over 6,000 cases per year. And primarily these cases are locally acquired, and less than 10 cases of rubella per year, and all of those cases have been imported. Currently, we have one licensed measles mumps rubella vaccine, the MMR2, manufactured by Merck. And this work group was established to evaluate the safety and immunogenicity of a new candidate MMR vaccine, Pyrex, manufactured by Glaxo, and data compared to the MMR2 vaccine. Next slide, please. We first met in January of this year, and the membership of the work group includes 17 members, including ACIP voting members, myself and Jamie Lair, ACIP liaisons and ex officio and CDC experts, and all representing a broad range of expertise. Next slide, please. The policy topic under consideration is the equivalency and usage of a new MMR vaccine compared to the currently licensed MMR. And our planned work group activities include a review of the safety and immunogenicity data for the new and currently licensed MMR vaccine, to adjudicate a non-inferiority of the vaccine candidate compared to the currently licensed MMR vaccine, and we will consider its use for licensed indications and existing ACIP recommendations for the prevention of measles, mumps, and rubella, including concomitant use with other childhood vaccines, interchangeability of its use in the MMR vaccine series, and finally to develop MMR vaccine policy options that ACIP may consider for recommendations. Next slide, please. And today we will hear a presentation of the data by GSK on the safety and immunogenicity as compared to MMR2. And over the spring, up to the June meeting, the work group will hold monthly meetings and additional ones as needed, and use the evidence to recommendations framework to assess the available evidence. And at the June ACIP meeting, the work group plans to present policy options for consideration by ACIP with a possible vote if it's determined it is necessary, and if this candidate MMR vaccine should be licensed by FDA. And next slide. Today you've heard the introduction from me, and we will now hear an overview of GlaxoSmithKline's MMR vaccine candidate. And we have two questions for ACIP members to consider as they listen to this presentation. Next slide. does the data presented today support the equivalency of these two vaccines? And what additional data would you like to see to consider equivalency and interchangeability? And with that, I'll turn it back over to you, Grace, and to Glaxo to present their information.
Thank you so much, and thank you for those questions, for helping to frame the discussion. We'll turn it over to Dr. Abu El-Yazid from GSK to present their data on the MMR vaccine.
Thank you, Dr. Lee. Good afternoon. Can you hear me okay?
We can. Thank you very much.
So my name is Rimon Abu-El-Yazid. I am a medical and clinical affairs physician at GSK. Thank you for the opportunity to present the safety and immunogenicity of Pyrex GSK MMR vaccine. Next slide, please. The GSK MMR vaccine was first licensed in Germany in 1997 under the trade name Pyrex. It is currently licensed in more than 100 countries worldwide, including all European countries, Canada, Australia, and is pre-qualified by WHO. GSK submitted a biologics license application to FDA in June 2021, and the anticipated action date is June 2022. For FDA registration, the GSK clinical development program demonstrated that Pyrex is 1. Aligned with the ACIP recommendations for measles, mumps, and rubella vaccination. 2. Has non-inferior immune response and comparable safety to MMR2. And 3. Can be used interchangeably in individuals who previously received MMR2 or ProQuad. Next slide, please. The proposed indication for Pyrex under FDA review is active immunization for the prevention of measles, mumps, and rubella in individuals aged 12 months and older. The proposed dose is 0.5 ml by subcutaneous injection. The first dose is administered at 12 to 15 months of age, and the second dose at 4 to 6 years of age. The second dose may be administered before age 4, provided there is a minimum interval of 4 weeks. For catch-up, the second dose may be administered at 7 years and older. Next slide, please. The development plan in support of the BLA consisted of 1 phase 2 and 5 phase 3 studies. The phase 3 studies enrolled over 16,000 subjects, approximately 50% of whom were enrolled in the US. The 5 phase 3 studies included subjects aged 12 to 15 months, study 160, 161, 162, 4 to 6 years, study 158, and 7 years and older, study 159. 3 studies, 158, 159, and 160, assessed the non-inferiority of Pyrex at the release potency for the US compared to MMR2 in terms of immunogenicity. Study 160 also demonstrated manufacturing lot-to-lot consistency. The immune response of the end of shelf life potency lots was demonstrated in study 161, and the safety of the upper release limit of potency in study 162. Next slide, please. This study is really busy, but the racial and ethnic distribution of the overall study participants and the US population are shown in the table, and the demographic profile of the study participants is representative of the ethnically diverse US population and was similar between those who received Pyrex and MMR2. Next slide, please. In the next slide, I will present the safety data of Pyrex first dose in children aged 12 to 15 months and in children who received a second dose 6 weeks later. I will then discuss safety in children aged 4 to 6 years and individuals aged 7 years or older who received Pyrex as a second dose of MMR vaccine. Next slide, please. In all trials, solicited local and general symptoms, unsolicited and serious adverse events were collected according to the interval shown in the slide. Next slide, please. Study 160 was a randomized observer blind controlled study in which subjects aged 12 through 15 months received a first dose of Pyrex or MMR2 administered concomitantly with U.S. licensed vaccine. The frequency of reported solicited local and general adverse events were similar in both groups. The most frequently reported solicited local adverse event in both groups was injection site pain, 26% in Pyrex and 28% in MMR2. Irritability fuzziness was the most frequently reported general solicited adverse event, 63 in Pyrex, 66 in MMR2. Next slide, please. In study 161, a randomized observer blind controlled clinical study, subjects aged 12 through 15 months received a first dose of Pyrex or MMR2 followed by a second dose of the same vaccine 6 weeks later. As shown in the table, both those two, the frequencies of reported solicited local and general adverse events were similar in both groups and were slightly lower than those reported after the first dose. Next slide, please. A subset of subjects were evaluated for local and general adverse events in study 158, a randomized observer blind controlled study where subjects aged 4 to 6 years received Pyrex or MMR2 as a second dose. These children received the initial dose of MMR2 or Proquat in the second year of life. In this subcohort, the reactogenicity profile was similar between Pyrex and MMR2 groups. The most common solicited local adverse event was pain at the injection site, 41% in both groups. The most common solicited general adverse event between day 0 and day 42 was fever, 24% in Pyrex and 25% in MMR2. Next slide, please. In study 159, subjects aged 7 years and older received Pyrex or MMR2 as a second dose following pre-birth administration of a combined measles, mumps, and rubella containing vaccine. The reactogenicity profile was similar between the two vaccine groups. Next slide, please. Let us turn now to review the immune response data. In agreement with FDA, the efficacy of Pyrex was inferred based on the comparative immunogenicity data with MMR2. Next slide, please. In study 160, subjects aged 12 through 15 months received first dose of Pyrex or MMR2 given concomitantly with hepatitis A vaccine and varicella vaccine. Children enrolled in the U.S. also received PCV13. The predefined non-inferiority success criteria after the first dose of Pyrex compared with MMR2 were demonstrated in terms of seroresponse rates and antibody geometric mean concentrations to measles, mumps, and rubella antigen. Next slide, please. In study 161, subjects aged 12 through 15 months received the first dose of Pyrex or MMR2, followed by a second dose of the same vaccine 6 weeks later. In a descriptive analysis in a subset of subjects, the immune response after the second dose was similar between the two groups in terms of seroresponse rate and antibody geometric mean concentration for all antigens. Next slide, please. In study 158, subject 4 to 6 years received Pyrex or MMR2 as a second dose after an initial dose of MMR2 or Proquat in the second year of life. Pyrex and MMR2 were given concomitantly with Cholera, diphtheria, tetanus, cellular pertussis, IPV, and varicella vaccine in a subset of subjects. As you see from the slide, the predefined non-inferiority criteria were met for seroresponse rate and antibody geometric mean concentration for all antigens. Next slide, please. In study 159, subject aged 7 years and older received Pyrex or MMR2 as a second dose after previous administration of a combined measles, mumps, and rubella vaccine. The predefined non-inferiority criteria were met for all comparisons. Next slide, please. Interchangeability is an important clinical consideration. In the development plan, we studied the use of Pyrex after a previous dose of other MMR vaccines. And based on the comparable immunogenicity data in prime subjects who received either MMR vaccine in studies 158 and 159, the data demonstrate that Pyrex can be administered interchangeably as a second dose to individuals who have received the first dose of another measles, mumps, and rubella containing vaccine. Next slide, please. The concomitant use of Pyrex with other routinely administered childhood vaccine was evaluated with hepatitis A vaccine, varicella vaccine, and PCV13 in study 160 in children aged 12 to 15 months. And with DTaP IPV and varicella vaccines in study 158 in children aged 4 to 6 years. There was no evidence that Pyrex interfered with the antibody responses to antigens in the previously mentioned vaccines compared with the immune responses of MMR2 co-administered with these same vaccines. Next slide, please. ACIP recommends MMR vaccination as young as 6 months of age in an outbreak or prior to international travel. I would like to share the results of 2 open-label randomized controlled phase 3 studies conducted in Singapore and India. These studies evaluated the immunogenicity and safety of 2 doses of Pyrex co-administered with 1 or 2 doses of the GSK monovalent varicella vaccine Pyrex in healthy infants beginning at 9 months of age. The seroconversion rate after 1 dose for measles was in the range of 88 to 93%, for mumps 83 to 92%, and 100% for rubella. Nearly all children greater than 99% seroconverted for all antigens after completing the 2-dose vaccination schedule in both studies. The two studies concluded that Pyrex was well tolerated and immunogenic when administered to children as young as 9 and at 12 to 15 months of age. Next slide, please. So let me conclude on safety of Pyrex. Overall, the safety data collected during Pyrex development have not identified a safety concern and are comparable to the safety profile of MMR2. Pyrex is generally well tolerated in subjects 12 to 15 months of age, 4 to 6 years of age, and 7 years or older when given as a first or a second dose. The safety profile of Pyrex co-administered with a range of routine childhood vaccinations is comparable to that of the MMR2 co-administered with the same vaccine. In conclusion, the safety profile of Pyrex, including that at the maximum release potency, is acceptable and comparable to the safety profile of MMR2. In addition, post-marketing safety surveillance of Pyrex outside the U.S. showed no significant safety concern and confirmed an acceptable safety profile consistent with the U.S. registration studies. Next slide, please. Finally, I would like to summarize GSK conclusion on immunogenicity of Pyrex. The clinical trial data demonstrated non-inferiority of the immune responses of Pyrex compared to MMR2 in terms of seroresponse rate, geometric mean concentration in children 12 to 15 months of age after a single dose, and in children 4 to 6 years and individuals 7 years or older when Pyrex is given as a second dose of MMR vaccine. The data support the dosing schedule recommended by ACIP for MMR vaccination. Pyrex can be administered interchangeably to individuals who received the previous vaccination with MMR2 or Proquat. Pyrex can be co-administered with routine U.S. pediatric vaccine. Next slide, please. So in summary, GSK MMR vaccine program has met the development objectives to bring Pyrex to the U.S. market. And from a public health perspective, the availability of a second MMR vaccine would be beneficial. And before I finish, I would like to thank all volunteers and their families, as well as the investigators and the study staff involved in the GSK MMR vaccine studies. Thank you very much.
Thank you so much. This presentation is open for questions. And I just actually want to take a moment to recognize and thank the presenter for enrolling diverse populations in the clinical trials. It's really important to the committee, and seeing the diversity reflected in the study participation is incredibly helpful. Dr. Daly.
Yeah, thanks so much for that presentation. And I have 3 or 4 safety-related questions. And Dr. Lee, if you don't mind, they're pretty brief. So if I could sort of just take them in order, that would be great. So my first question was, what on several slides you had a term meningism, and I'm just not familiar with that term, and it was combined with febrile seizures. So could you tell us what that term refers to? And again, I apologize that I'm just not familiar with it.
Sure, thank you. Well, it is just meningeal irritation, which included like headache, stiff neck, blurring of vision in older children, and it could include convulsion. So we collected all of that, including febrile convulsion.
Okay. Yeah, I mean, so these were not kids that were diagnosed with clinical meningitis. It's just symptoms based on that.
Meningeal irritation, yeah.
Okay. Yeah, I mean, I think of that as different, probably pathophysiologically, than a febrile seizure. But okay, thank you for that. Then there were several febrile seizures. Were those sort of characteristic of what we typically see following MMR2, meaning 7 to 10 days after vaccination? And this is, I'm speaking from the phase 3 clinical trials, yeah.
Correct. So again, febrile seizures were reported as a part of the meningeal irritation within 43 days following each vaccination, and there are very few. So for post-dose 1 in study 157, which is a phase 2 study, and 160, 161, and 162, all of these in the children 12 to 15 months, we find 16 cases out of 6,441 in Pyrex. That means 0.25%, and 7 cases out of 3,361. That's 0.2% in MMR2. So, and only 5 cases of these 15 are related, which represented 0.08% in Pyrex, and 5 cases out of the 7 are related, which represent 0.14 in the MMR2. Sorry for all these numbers.
Okay. Yeah. Thank you for that, and thanks for having that handy. I guess that my last question is about whether you have estimates of the rate of vaccine-associated febrile seizures following Pyrex from post-authorization studies elsewhere in the world, and related to that, whether you have any estimate of the rate of thrombocytopenia following Pyrex given, again, post-authorization elsewhere in the world. Thank you.
Yeah, so I will answer the second question first. Well, for the immunocytopenic purpura, we find very, very few cases, actually none in the Pyrex group, and only 1 case out of 3,395 in the MMR2. That means representing 3 per 10,000. For post-marketing surveillance, IPT reported in line actually with the literature, which is around 2.6 per 100,000 vaccine dose. For febrile seizure, again, I don't have the information on hand, but I can provide that later on. But in our clinical trial, they are very, very low, as I presented.
Yeah, thank you very much for that. And again, thanks for having that at your fingertips. I would appreciate seeing the post-authorization non-U.S. data for febrile seizure rate at a future meeting. Thank you.
Thank you, Dr. Daly. We'll move on to Ms. McNally.
Thank you. I'm the consumer representative, and I'm just trying to understand if when it's co-administered or it's used interchangeably, is there any difference in reactogenicity? And also, can you please comment on how this vaccine might be examined in a younger age group for a COVID vaccine in terms of co-administration? Thank you.
So let me understand. You are saying co-administration with COVID?
Yeah, the COVID vaccine.
Yeah, so this program actually started in 2008, and we finished all clinical trials in 2014, so that's before COVID. So definitely we'll consider that if the committee wants us to do a study.
Thank you. And how about the reactogenicity when it's used interchangeably and with other MMR vaccines, and also when it's co-administered with other vaccines other than COVID?
So thank you for this question. If I have a slide number, if I have a slide number 8, please. So in this slide, you can see this is with co-administered vaccine, and it's written in the slide. It's with Pyrex, which is hepatitis A vaccine, varicella vaccine, and PCV13. And you can see here, there is no difference in adverse event between the group received Pyrex and the group received MMR2. And for interchangeability, if we can go to a study, slide 10, please, two slides from that. This study, which is 158, the subject received either Pyrex or MMR2 after a previous dose of MMR2 or Proquat. And you can see here the safety in the group received Pyrex and the group received MMR2. There is no difference.
Great, thank you.
Thank you. Dr. Nelson. Dr. Cotton, sorry, Dr. Cotton.
Sorry, it's been a while since I've been called that. So thanks a lot for the presentation. My question is something that I don't know if you can actually answer, but we've done a fair amount of limited research over the years in transplant and other immunocompromised pediatric patients to show that it was safe for them when on very low dose immunosuppression for them to get the current MMR. And I know that I'm sure that GSK is not doing research in this. Is there any way of knowing whether this current vaccine would be similar to the prior? You know, would we anticipate any major changes with respect to our immunocompromised population? I don't know what your thoughts are, if you can answer that at all.
What I can tell you that this vaccine is the same and comparable safety to MMR2. So if you are using in your clinic MMR2, you can use that vaccine the same way. But we don't have specific data on immunocompromised.
Right. Okay, well, that's already very helpful to know. Thank you very much.
Thank you.
Dr. Sanchez?
Oh, yes, thank you. No, thank you for the presentation. I had a question on your slide on immunogenicity in infants less than 12 months of age. And this was, I believe, looking at the references, was done in Singapore. Do you know, was this, first of all, a maternal population? I mean, it's the infants, the mothers. Do you know if this was, the mothers had been vaccinated previously with MMR, or was this a natural infection that these mothers had previously? So it was an immunized population. And the other question that I had was, so relative to like their baseline, I mean, I only saw, you presented the post-dose 1 and post-dose 2. What was their baseline in their measles, mumps, and rubella antibody titers? And your definition for seroconversion was somewhat increased fold. I'm a little bit, just a little bit confused by how it's presented, and actually the role of maternal antibody in terms of how it affects these titers.
So the role, I have to review the data again for the studies in Singapore and in India to see if we collected the data from the mothers or not. But let me give you the definitions that we used for the sero response rate. So the sero response rate here is defined as the percentage of initially seronegative subjects with concentration above the sero response threshold for each assay. And the sero response threshold for measles is 200 milli international unit per ml, and for mumps, 10 ELISA unit per ml, and for rubella is 10 international unit for rubella, and these are the WHO definitions.
So then these infants, their baseline were negative titers for measles?
No, if they are positive, they have to be excluded from the analysis.
Thank you.
Thank you, Dr. Saneas.
Thank you. Are there any studies of use of Pyrex in adults who are not immune to one of the three components, or is Pyrex used for adults in other countries?
So the indication that we are seeking from FDA, which is under approval, is individual aged 12 months and older. So you can use it for catch-up in older population. And we did the study 159. That's the study. Actually, we did it in 7 years and older. And about let me make sure that I will say the number correct. About 2/3 of the participants let me tell you the age distribution here. Yes. So at the time of the vaccination, their mean age was 26 years, and 36% of the subjects were aged 7 through 17, and 64 of the subjects were about 18 and above.
Thank you.
Thank you. Dr. Long.
Yes, thank you. I have a quick clarifying question and then another, which is more of a comment of what I think I would need before we voted on such a thing. The first is on one of your slides with one of the studies, this first study, I think, in the 12 to 15-month-old age group. In quotes, you have maximum, or in parentheses, maximum potency. Do I understand that that is the same dose you used in all the studies?
No, the maximum dose. So this, to license in the U.S., you have to actually define the minimum and maximum potency. So for minimum, you have to be immunogenic. For the maximum, you have to be safe. So we only did one study with maximum potency, and this is what study 162, and primary objective is safety. And as presented here, it was safe.
Dr. Daly.
Well, I really appreciate
I'm not
that.
finished.
Yeah,
Oh, I'm sorry.
Sorry,
Yeah.
Dr. Long.
Yeah, that's what I
I'm
was gonna
sorry.
say.
I thought he was showing us another. I'm still trying to process all that I just heard. So I think I would need to know with more clarity the dose that was used for immunogenicity from difference from study to study, and how that panned out, not lumped together, and also that maximum was, I think, probably 1,000 children, maximum potency, who got that. Because I'll tell you, the concerns that I have that are more along the lines of Dr. Daly's are really about febrile seizures. So first of all, febrile seizures are not reported spontaneously following MMR because they don't happen within a week of the vaccine, as Dr. Daly said. You have to grow the virus, and then you have to get the febrile illness to get you the febrile seizure, and that's all in the second week. So it had the exact same incidence as fevers following the old wholesale pertussis vaccine. About 1 in 1,800 was the number. And it's just that the population doesn't associate it, and doctors don't always associate it. So you only learn about these when you're studying this prospectively. So the numbers that you report are very high. So I would want a 0.2 and 0.3 is 1 in 500 and 1 in 300. Those are very high. And I also think I understand from what you've told us that you don't have a single study that's just your MMR, but they are all concurrent with 2 and 3 other vaccines, all of which can cause fever and seizures, but they would do it at completely different times. So I would like the study group to have seen and be able to tell us the difference in the incidence of seizures, depending on what you got concurrently, what the number actually was, because you don't have that many. You only have a couple thousand children in the febrile seizure age, and you've put together meningismus and febrile seizures, which I agree with Dr. Daly are not the same kinds of things. And then the final thing about that was surprising from the data is that febrile seizures associated with MMR are not expected to occur at nearly the same frequency with your second dose, because the second dose is usually only picking up the 5 or 6% that you missed from the first dose. So you only have actual robust virus replication in 7% of your population. So it just doesn't, this all needs to be clarified, I think, so that we really understand the same and different. Thank you.
Well, thank you. Let me answer the last part of your question, because there are actually multiple questions, and I wish I have more time to present more data, but I was limited with just 15 to 20 minutes. So let us go to slide number 9, and that's the second dose in 12 to 15 months. And you see here the fever is 32.5%, and grade 3 is 3.5, and it is the same as MMR2, so there's no difference here. And the meningism and also the febrile convulsion was associated up to 43 days post-vaccination. And definitely I will present to the committee, separately in each study, what are the adverse events that happen with meningism and fever and febrile convulsions.
Yes, and we would like to see the febrile convulsions in the second week following immunization, and in the first 48, 72 hours. You could have a lot of things going on early on that would wash out any potential differences that might be occurring in the second week. So we'd like to see the second week separately. Thank you so much.
You're welcome.
Last question, Dr. Daly.
Yeah, thank you. In listening to Dr. Long's question, I realized I also didn't understand the maximum potency. Is it that potency varies lot to lot, or is it that you tried a higher dose? Over.
No, we tried higher dose to define what is the maximum release potency, to make sure that you have enough at the end of shelf life. So we did study 162, and this study was the primary objective with safety. I can actually tell you what is the minimum potency and maximum potency that have been done through this development. So for measles, for example, it was 3.4 log10 CCID50, and the maximum was 4.5 log10 CCID50. That's for measles. For mumps, it was 4.2 log10 CCDI50, and the maximum was 5.7 CCID50. For rubella, It was 3.3 log 10 CCID50, and the maximum was 4.4 log 10 CCID50. So you can see there is a wide range here from the minimum and maximum potency. So the minimum is defining end of shelf life. And the maximum this is the release potency to make sure that at the end of shelf life, you have enough potency of the antigen.
Okay, thank you very much. We do need to move on to the next session, which is the public comment period. I'm going to, ask, first I want to thank our speakers for the afternoon. Ms. Bata, I think there was a lot of feedback from committee members, and we're looking forward to any updates at the next session. And I think we are ready to go. So moving to the public comment period. Give me one moment. Okay, I'd like to welcome and thank our public comment speakers for addressing the committee today. All the speakers, as Dr. Wharton mentioned, submitted a request in advance of the meeting, and the final list of public commenters was determined via a lottery. For our speakers today, we have a limited public comment period, and in order to make it through all of the listed speakers, it's extremely important each speaker limits his, her, or their remarks to 3 minutes. There will be a timer displayed on the screen, so you know how much time you have left. As a reminder, our committee appreciates diverse viewpoints that are respectful in nature and focused on the issues being discussed today. Thank you again to our speakers, and we look forward to your comments. Our first speaker is Leah Russin.
Hi, can you hear me?
We can, thank you. Please go ahead.
Oh, good, I did it right. Thank you for your time. I know COVID isn't on the agenda for today, but as the parent of the 21-month-old child in the vaccine trial, I want to take a moment and acknowledge the confusion and frustration that we parents are feeling. I have 2 main points, both related to messaging, and both of which actually relate to your MMR discussion today. First, when explaining the vaccine approval process, because that's how we've always done it, isn't good enough. Explain what was considered, why it was rejected, and what's next. Please think as creatively as a scared parent in considering options that need explanation. For example, back in December, Pfizer's first press release indicated that data was strong for 2 doses of 3 microliters for toddlers, but not for age 2 to 5. Why couldn't we have considered authorizing a 2-dose series for toddlers before preschoolers back in December, allowing us to have protected at least some of our children through the Omicron wave? Because that's not the way we do things isn't a good enough answer. Also, why couldn't Pfizer have trialed a 5 microliter 2-dose series in addition to adding a 3rd dose of 3 microliters? 2 vaccine visits is already asking a lot for families. Again, because that's not how we do things isn't good enough. Explain to us why. Don't leave us bumbling around in Facebook groups and WhatsApp chats with hundreds of other parents, trying to figure out why what seems obvious to us isn't happening. Second, many physicians and other medical practitioners report that they are uncomfortable and lack confidence discussing vaccines with their patients. You are the experts. You have uniquely delved deep into the data and carefully assessed and weighed the risks of the diseases against the vaccine. I encourage you, when you do recommend a vaccine for approval, have staff take the time to prepare materials for public dissemination, reflecting your collective comments explaining why you personally recommend the vaccine. Your comments during and after voting are often eloquent and compelling, but they are inaccessible to medical professionals that ultimately might benefit from your wisdom and experience when discussing vaccines with their patients. In honor of Paul Farmer, please continue to push for equitable and easy access for healthcare for all. Thank you again for your time and your service to public health.
Thank you for your comment. Next, we'll move to Ms. Sarah Berry.
Hello, can you hear me?
You can. Please go ahead.
Hello, and thank you, ACIP. My name is Sarah Berry, and I'm an independent pro-vaccine advocate. Because these meetings are well attended and listened in by anti-vaccine activists, I think it's very relevant to talk about attitudes towards vaccines in general, and I'm going to read off a comment that an anti-vaccine activist made about me in regards to past public comments I have made to ACIP. Quote, Sarah is insane. Every chance she gets, she goes on about how parents abuse their autistics by trying to help them in any ways possible. We should just accept them and their suffering as normal. It's absolutely disgusting, unquote. I mention this comment because it is clear evidence that anti-vaxxers are incapable of adequately defending themselves from my specific form of criticism. And I need not just ACIP, but every pro-vaccine person in the world to know this. I have indeed given public comments to ACIP about the dangerous and, yes, abusive cures for autism that anti-vaxxers have created. Since the person who called me insane clearly did not listen to the facts that I have shared in previous public comments, I will go over some of them again because, again, this is something the anti-vaxxers are scared of, and that's important when we talk about vaccines. First, Carrie Rivera. She sold a book called Healing the Symptoms Known as Autism. A careful review of her book shows it is a manual that teaches parents how to force their children to drink bleach. Other methods in the book detail how to give bleach baths and even bleach enemas. Second, Mark Geyer. He lost his medical license for experimenting on autistic children by giving them dangerously high doses of a drug called Lupron. To get approval for his experiment, he created and oversaw an institutional review board along with his son, his wife, and other associates. It's an obvious breach of basic medical ethics, and if any vaccine manufacturer attempted such a thing, anti-vaxxers would rightly use it as an example of corruption. When it's one of their own, however, they look away. Lastly, Andrew Wakefield. Whenever anybody says his name, I want the next sentence to be about what happened to Jack Piper. If you don't know about Jack Piper, I will tell you. As per Wakefield's experimental protocol, Jack Piper was subjected to a colonoscopy that ended up piercing his bowel 12 times. He was 5 years old and had to stay in intensive care for 2 weeks. He also suffered multiple organ failure and even developed epilepsy. Even so, Andrew Wakefield is still a hero to the anti-vaccine community. Two of the biggest anti-vaccine voices are Robert F. Kennedy Jr. and Del Bigtree. When it comes to people like Carrie Rivera and Mark Geyer, I challenge Kennedy and Bigtree to think about how they have personally failed to call out the unethical and dangerous actions I have described today. If my comments calling out this failure are disgusting to anti-vaxxers, then so be it. I will not back down because I know that my method of talking about this situation is the way to solve the anti-vaccine misinformation crisis. Thank you again, ACIP.
Thank you for your comment. I just want to interject for a moment that, we are very much interested in hearing public comment about the votes. I want to recognize that there are many challenges out there with communication and whatnot. Our preference is to use public comment to focus in on the issues at hand, and again, not to focus on individuals as opposed to the issues. Thank you very much. Next, we'll move on to Mrs. Barbara Lopke.
Good afternoon, Chairwoman Lee and the committee. My name is Barbara Lepke. I'm a mother, grandmother, and advocate. Something good has occurred with the COVID vaccine, and that is that more of the American public has started attending the FDA and CDC meetings online and taken an interest in what you do. This also means, though, that they're asking more questions, and I've been asked to present a few of those today, and perhaps you can address these now or in the future. One concern I've been told is that adverse events seem to be diluted by the listing of redness at the injection site and pain at the injection site as the most common complaints. This makes other more concerning adverse events get bumped down the list and not mentioned. This is something the public expects from the manufacturer, but the public believes the CDC is working for them, and they'd like to know more about the serious events than just the redness caused by the puncture of a needle. As the committee continues to give their COVID vaccine recommendations in the future, can you tell the public when Comirnaty will actually be used in the U.S.? Some are under the impression that they're getting the actual licensed product when they're still getting the emergency authorized version. Is Comirnaty not used in the U.S. yet due to the VICP process? And if it isn't, when will it be? Have you detected a signal on new suicidal ideations from the COVID vaccines? A quick search of VAERS showed over 900 entries in the report. And so far, I don't believe this has been mentioned in any of the meetings. Can you tell us how many reports of death from the COVID vaccines are currently being held back for review? And could you go through the process in one of the meetings of how a vaccine comes before the committee? I think there's a lot of people that would like to know that answer. And finally, just as we can't give you legal advice about the meetings and shutting down a public comment, neither can anyone else who's not a licensed attorney in the U.S. With more of the public attending online each time, it would likely further diminish the image of the CDC. And currently, in the last couple of days, that's been diminished with reports that there's been data pulled back. Thank you so much for your time. We appreciate the work you put in, and we await your responses to a few of the questions the public has. Thank you.
Thank you very much for your comment. Next, we have Marla Dalton.
Good afternoon. I am Marla Dalton, Executive Director and CEO of the National Foundation for Infectious Diseases, or NFID. On behalf of NFID, as a longstanding partner of CDC, we appreciate the valuable work of ACIP in guiding U.S. immunization policy and protecting public health through the ongoing review and analysis of vaccine safety and efficacy data. Recommended vaccines help protect individuals of all ages from serious diseases, including flu, pneumococcal disease, hepatitis B, and measles, among others. And although annual flu vaccination is important for everyone aged 6 months and older, adults aged 65 and older are at greater risk of flu-related complications, including hospitalization and death. Yet, despite the availability of safe and effective vaccines to help prevent disease, immunization rates remain suboptimal across populations for nearly all recommended vaccines in the U.S. And this problem has only been exacerbated by the COVID-19 pandemic, with routine vaccinations declining significantly across all age groups. These declines are dangerous to public health. We can no longer delay life-saving vaccines, and we must address the concerning decline in vaccination rates. Low immunization rates contribute to poor health outcomes, and they carry a high price tag for society as a whole. The U.S. spends an estimated $26.5 billion annually treating adults with flu, pneumococcal disease, shingles, and pertussis. NFID urges additional action to ensure that all populations are vaccinated as recommended. We must work together to help protect individuals and society as a whole. It is not enough to have safe and effective vaccines. We must ensure these vaccines are used as intended. Thank you all for the important work you do to protect public health and for your tireless and dedicated service.
Thank you for your comment. Next, we'll move to Ms. Clarissa Garcia.
I'm confirming that you can hear me.
We can hear you just fine. Thank you.
Hi, I'm Clarissa Garcia, our Executive Portfolio Lead for Patient Education Programs. On behalf of the American Heart Association, I welcome this opportunity to publicly share comments with the ACIP. The COVID-19 pandemic has affirmed that chronic diseases and infectious diseases are inextricably linked. We offer these comments about recommendations to strengthen influenza vaccination guidance as essential for protecting health and preventing adverse outcomes equitably. In El Paso, Texas, we observed lower than average influenza-related hospitalization rates, in part due to our CDC-funded iReach efforts over the past 2 seasons. We believe decreased rates were a direct result of a mix of the following: consumer and healthcare, professional education and mobilization, community access, the distribution of high-dose influenza vaccine, and COVID-19 mitigating measures such as mask wearing and social distancing. The AHA supports operationalizing the Vaccine for Adults program, that is a federally funded, nationwide, evidence-based adult vaccination program in the United States. The program focuses on vaccinating underserved racial and ethnic communities, Medicaid beneficiaries, and adults aged 65 years or older. Specifically, the AHA supports the availability of the high-dose influenza vaccine for seniors during influenza season in hospitals, clinical care settings, community pharmacies, and other locations that get vaccines to people. The AHA endorses rapid ACIP reviews of all relevant science related to influenza vaccines, standard and high dose. Enhanced availability of high dose and standard dose influenza vaccines creates a unique opportunity to explore disparities in standard dose influenza uptake against racial and ethnic groups, in addition to analyzing the structural and systemic factors affecting access to high-quality vaccination services. The AHA aligns its recommendations regarding influenza vaccine with ACIP recommendations and revises recommendations to align with updates from ACIP. The American Heart Association will do its part to improve equitable influenza vaccine access and uptake, with an emphasis on educating both the consumers and healthcare professionals. Our message: administer the most effective influenza vaccine based on age and underlying medical conditions. We will be submitting more comprehensive written documents for consideration, and I thank you for your time today.
Thank you for your comment. Next, our public speaker is Dorit Rice.
Hello, can you hear me?
We can. Thank you very much.
Thank you. My name is Dorit Rice, and I'm a professor of law at the University of Hastings College of the Law. Thank you again for the opportunity to comment. You've heard a lot about issues in messaging, so I want to start by saying that one of the good things about this committee is the high level of transparency, where the data, good or bad, is presented in such transparent, thorough ways. To give just one example of the many wonderful presentations we've seen today, the careful examination of the studies of the comparative influenza vaccine involves not just a clear, in-depth discussion of the data, but also the limitations of it. And that's been true throughout. So I know you, the committee, and its staff work really hard to make data accessible and transparent. And I know you came up with some creative, great ideas. For example, your previous illustration of the benefits of influenza vaccine. And I wanted to thank you for your efforts to increase transparency. I appreciate them, and I know a lot of people do. I also want to remind the committee that generally the people who are subject to your recommendations are lay people and won't come in with a preference between vaccines or an opinion and depend on doctors that draw on you. I want to echo Ms. Rustin's recommendation that some handout or some information summarizing the wonderful comments made by the committee might be helpful to doctors in giving points to people on why they should get this vaccine. I know you have a lot to do. I know you've done a lot. I would consider whether there's a way for you to also put out summaries of the important points that the committee made in support of the recommended vaccine. I also want to echo Dr. Dalton's point about the importance of emphasizing routine vaccines, and I was glad that this meeting gave attention to them because we know we have a problem. We know that COVID that interrupted our life in so many ways also interrupted immunization rates across the board, and it's time to put an emphasis on that. And finally, I want to encourage you, if you want to preserve oral public comment, and as I said in the past, I think you can legally and legitimately move to written comments, but I understand why you'd hesitate to do. But if you want to preserve oral comments, I want to encourage the committee to post slides at least 2 days in advance, at least for routine meetings. I know that before you've made an effort to increase transparency by, for example, making sure people are notified about public commenting beforehand and putting the agenda up, and I appreciate your efforts. I know it's been a rough 2 years, but putting the slides up in advance will have people make the public comments more meaningful. In this case, the MMR slides were still not up this morning, so I hope that improves. Thank you again for all your work.
Thank you for your comment, and I want to thank all of our public comment speakers today, as well as those who submitted written comments as part of this meeting. We will now move to the vote. We're going to move right in, and I'm going to ask Dr. Susan Hills to put up the language for the revised language for the votes. We'll take them one at a time. Dr. Hills, would you please go?
Thank you, Dr. Lee. So the first vote is the proposed recommendation for laboratory workers, and the language is TBE vaccination is recommended for laboratory workers with a potential for exposure to TBE virus.
Thank you. We'll pause there for a moment and ask if there are any additional questions or issues the committee or any others would like to discuss before this particular vote number 1 for TBE vaccines. Oh, thank you, Dr. Daly. I see your camera on. we can do that at the time of the vote. I'm happy to put my camera on now, but I do want to ask and take a moment to pause since it's been a little bit of time since we discussed the prior votes. Are there any questions? Okay, I don't see any hands raised. So I'll assume the committee has no objections to proceeding with the vote. ACIP members, now you can please turn on your video, state your name, whether you have a conflict of interest, and then your vote. And as you know, I tend to go out of order, so be prepared. But I do see Dr. Daly, your name, whether you have a conflict of interest in your vote.
Matt Daly, no conflict of interest, and I vote yes.
You. Ms. Bata.
Lynn Bata, I have no conflict. I vote yes.
Thank you. Dr. Alt is frozen on my screen, I think. We'll move to Dr. Palin.
You're cutting out a little bit. I was having trouble hearing you. Do you want me to go ahead?
Oh, yes, Dr. Oh, sorry. Yeah, I think my internet connection might be unstable.
Alt, no conflict, yes.
Thank you. Dr. Palin.
Kathy Paling, no conflict. Yes.
Thank you. Dr. Talbot.
Talbot, no conflicts, and yes.
Thank you. Dr. Sineas.
Sineas, no conflict, yes.
Thank you. Dr. Bell.
Bell, no conflicts, yes.
Dr. Brooks.
Oliver Brooks, no conflicts, I vote yes.
Dr. Long. Dr. Long?
I'm sorry, I am having as much trouble as you, Grace. Sarah Long, no conflict, yes.
Thank you. I think I can see everybody. Ms. McNally?
McNally, no conflict, yes.
Thank you. Dr. Sanchez?
Pablo Sanchez, no conflict, yes.
Thank you. Dr. Lair?
Amy Lair, no conflicts, yes.
Thank you. Dr. Chen?
Gilbert Chen, no conflicts, yes.
Thank you. Dr. Cotton?
Camille Cotton, no conflicts, yes.
Thank you. And Grace Lee, no conflicts, yes. So vote number 1, the proposed recommendation for laboratory workers for TBE vaccines passes with 15 yeses and 0 nos. And let us please move on to the vote number 2.
So vote number 2 is for persons who travel abroad. And the first component is a recommended component, which is TBE vaccine is recommended for persons who are moving or travelling to a TBE endemic area and will have extensive exposure to ticks based on their planned outdoor activities and itinerary.
Thank you. Any comments, questions, clarifications needed for this vote? Okay, I don't see any committee members' hands raised, so we'll go ahead, and I see Dr. Paling in the middle of my screen. Dr. Paling.
Hi, Kathy Paling, no conflicts, yes.
Thank you. Ms. Bata.
Really out of order. Lynn Bata, no conflict, yes.
Thank you. Dr. Chen.
Gilbert Chen, no conflicts, yes.
Thank you. Dr. Lair.
Amy Lair, no conflicts, yes.
Thank you. Dr. Long.
Sarah Long, no conflict, yes.
Thank you. Dr. Brooks.
Oliver Brooks, no conflicts, yes.
Thank you. Dr. Cotton.
Camille Cotton, no conflicts, yes.
Thank you. Ms. McNally.
McNally, no conflict, yes.
Dr. Sanchez.
Pablo Sanchez, no conflict, yes.
Great. I seem to have let Dr. Daly.
Matt Daly, no conflicts, yes.
Great. Dr. Bell.
Bell, no conflicts, yes.
Thank you. Dr. Alt.
Alt, no conflicts, yes.
Thank you. Dr. Saneas.
Saneas, no conflicts, yes.
Thank you. Dr. Talbot, did I get you?
You didn't. Dr. Talbot, no conflicts and yes.
Thank you. And Grace Lee, no conflicts, yes. So vote number 2 passes with 15 yeses and 0 noes. And we will move on to vote number 3. Dr. Hills, if you wouldn't mind reading the revised vote number 3.
Thank you, Dr. Lee, and I will point out that I have clarified with the ACIP Secretariat and CDC that may be considered is appropriate in this setting, so that is the language for the vote. So vote 3, the shared clinical decision-making component, is that TBE vaccine may be considered for persons travelling or moving to a TBE endemic area who might engage in outdoor activities in areas ticks are likely to be found. The decision to vaccinate should be based on an assessment of their planned activities and itinerary, risk factors for a poorer medical outcome, and personal perception and tolerance of risk.
Thank you very much. Any questions, clarifications? Okay, we're going to start with Dr. Lair.
Amy Lair, no conflicts, yes.
Thank you. Dr. Bell.
Bell, no conflicts, yes.
Thank you. Ms. McNally.
McNally, no conflict, yes.
Thank you. Dr. Long.
Excuse me, Sarah Long, no conflict, yes.
Thank you. Dr. Brooks. Dr. Brooks.
Oliver Brooks, no conflicts, yes.
Thank you. Dr. Talbot.
Kip Talbot, no conflicts, yes.
Thank you. Dr. Chen.
Gilbert Chen, no conflicts, yes.
Thank you. Dr. Sanchez.
Pablo Sanchez, no conflict, yes.
Thank you. Dr. Paling.
Kathy Paling, no conflict, yes.
Thank you. Dr. Cotton.
Camille Cotton, no conflicts, yes.
Thank you. Dr. Saneas.
Sybil Saneas, no conflicts, yes.
Thank you. Dr. Daly.
Matt Daly, no conflicts, yes.
Thank you. Ms. Bata.
Bin Bata, no conflict, yes.
Thank you. And Dr. Alt.
Alt, no conflicts, yes.
And Grace Lee, no conflicts, yes. So vote number 3, the shared clinical decision-making component, passes with 15 yeses and 0 noes. I'll just take a moment to ask if anyone has anything they would like to add or make any comments or statements about their vote. It's optional, not required.
Camille Cotton, I would just like to say, as somebody who's done practice travel medicine for over 20 years, I'm really happy about this overall recommendation, and I think it provides flexibility, and clinicians practicing travel medicine hopefully will really enjoy the flexibility and thoughtfulness that went into this recommendation.
Thank you, Dr. Cotton. And I just want to commend Dr. Paling and Dr. Hills for their leadership of this work group. Poor Dr. Paling has had many work groups that have been active and busy, and complicated issues, but really recognize the importance of this and want to thank you for your leadership. Dr. Chen.
Yeah, I had the pleasure of serving on this work group for more than a year, and we had a lot of discussions. So I just wanted to congratulate and thank Dr. Paling for heading this, and also Dr. Hills for guiding the discussions and really doing all the hard work for her team to put this all together. I just wanted to make a comment that, even though we don't perceive that the burden of TBE is large, and it might be difficult to perhaps implement this vaccine because of the complexity of trying to understand, where the tick habitat is. But with the trends of global warming, we're seeing, tick habitats and mosquito habitats and flaviviruses continue to circulate. So this is just a reminder that flaviviruses, among which dengue, West Nile, yellow fever, continue to scourge the world. And so I think that we will see these types of vaccines becoming more and more important. So that's just my comment.
Thank you, Dr. Chen. Appreciate that very much. Okay, I don't see any additional hands raised. So with that, I'd like to move to the next vote, which is on cholera vaccines. Dr. Collins, would you be willing to take us through the revised vote language?
Yes, the new language is lyophilized CVD 103 HDR is recommended for children and adolescents aged 2 through 17 years traveling to an area with active cholera transmission.
Thank you. Any questions, clarifications needed from committee members? Okay, I don't see any hands raised. So we're going to proceed with, Dr. Long, please go ahead. Oh, except Dr. Long, you're muted.
Sorry. Did this always say lyophilized? CVD, I know the CVD 103H, right. Lyophilized, there are a lot of things, Haemophilus vaccine was lyophilized. I don't know why that's in the title, and I would have wanted to have some indication in the title that this is a this is a special vaccine. I take back everything I just said. I think it's fine.
Okay.
I'm sorry. I'm confusing.
Okay, Dr. Long.
I'm confusing.
All right. No, that sounds good. So for the cholera vaccine vote, this particular vaccine formulation is recommended for children and adolescents 2 to 17 years traveling to an area with active cholera transmission. Don't see any other objections or concerns at this time, so we'll move ahead to a vote. I'm going to start, actually, Dr. Long, I'm going to start with you.
Well, good. I'm remembering my name is Sarah Long. I have no conflict. And it's a yes.
Thank you, Dr. Long. Dr. Cotton.
Neil Cotton, no conflicts, yes.
Thank you. Dr. Cineas.
Cineas, no conflicts, yes.
Thank you. Dr. Alt.
Alt, no conflicts, yes.
Thank you. Ms. Bata.
And Bata, no conflict, yes.
Thank you. Dr. Paling.
Paling, no conflict, yes.
Thank you. Dr. Talbot.
Talbot, no conflicts, yes.
Thank you. Dr. Sanchez.
Pablo Sanchez, no conflict, yes.
Thank you. Dr. Lair.
Amy Lair, no conflict, yes.
Thank you. Dr. Brooks Costello, I was going to call on him. Dr. Brooks.
Oliver Brooks, no conflicts, yes.
Thank you. Ms. McNally.
Allie, no conflict, yes.
Thank you. Dr. Chen, and actually just a reminder, Dr. Wharton and McNeil, if there is a potential conflict, does he vote and abstain?
Yes.
Okay, so Dr. Chen, please go ahead.
Yes, Wilbur Chen. Let me mention my conflict of interest, which is that my employing institution, the University of Maryland, received a grant from Emergent Biosolutions that supported the work that I conducted to develop a Shigella vaccine. So this does constitute a conflict of interest. for this vote, and so I will abstain from this vote.
Thank you, Dr. Chen. Dr. Bell?
Bell, no conflicts, yes.
Thank you. Dr. Daly?
Matt Daly, no conflicts, yes.
Thank you. Grace Lee, no conflicts, yes. Did I get everybody on the committee? All right. Thank you, everyone. So this vote passes with 14 yeses, 1 abstain, 0 noes. And we now will have a cholera vaccine available for children and adolescents 2 to 17 years of age. Would anyone like to make any comments before we head towards meeting closure? Dr. Chen.
So, I think that having a cholera vaccine is terrific, but this also just reminds me to just mention that there are a lot of other diarrheal disease agents throughout the world, and these are agents that afflict vulnerable populations, so very young children, but also low and middle income countries, basically countries that don't have intact clean water, sanitation, and hygiene. And so my career is trying to develop other diarrheal vaccines, but I think, again, it's just to say that this is one of these agents that creates large inequities in populations that it afflicts. And so I'm happy to see this kind of vaccine being available here in the U.S., but I continue to want to aspire to see these types of vaccines being available in the countries in which these diseases are endemic. Thanks.
Thank you, Dr. Shen. Any other comments? Okay. I believe the committee has completed its business for today. Dr. Wharton, colleagues in the CDC room, are there any additional issues or items we need to discuss?
Dr. Lee, I don't believe so. I think we can adjourn until tomorrow morning.
Great. Any objections to adjourning the meeting? All right. Hearing none, today's ACIP meeting is now adjourned, and we'll see everyone tomorrow morning. Thank you for your time today.